Hello, and welcome to this Clinical Pharmacology and Therapeutics podcast. During this podcast, I want to talk about anticoagulants and thrombolytics. In terms of anticoagulants, the two most important agents that you should be familiar with are heparin and warfarin, and certainly as a junior doctor, you'll come across both of these agents on your day-to-day activities on the wards. So let's start by talking about some of the most important indications for using anticoagulants. Anticoagulants can be given either enterally or parenterally. Now, typically parenteral anticoagulants include heparin, and this is indicated in a number of situations. You should, of course, be familiar with its use in acute coronary syndrome, together with aspirin and clopidogrel. You should also be familiar with its use in both the treatment and prophylaxis of deep vein thrombosis and pulmonary embolism. Lastly, you should be aware that it is commonly used in the context of acute arterial obstruction and for extracorporeal circuits. In terms of warfarin, the most important indications are atrial fibrillation, which I'm going to talk a little bit more about in a moment, in the treatment of DVTs and PEs, for patients who have recurrent DVTs and PEs as prophylaxis, in the context of mechanical heart valves, and then lastly in some types of cardiomyopathy. So if we just return to the context of warfarin in atrial fibrillation, there is an important scoring system that you use to decide whether a patient with new onset or indeed established atrial fibrillation should be on warfarin. This is the CHADS or CHADS-2 score, which is shown here. C is for congestive heart failure, and atrial fibrillation with this will score you 1 point. H is for hypertension, 1 point. A, age greater than 75, 1 point. D is for diabetes, 1 point. And finally, S is for prior stroke or TIA, and this scores you 2 points. The scoring system, as I said, is important because it determines what sort of prophylactic therapy one should take against stroke. If patients score 0, they can be considered low risk and aspirin used. If they score 1, then they are considered moderate risk and either aspirin or warfarin may be used, and a discussion should take place between patient and physician about which is preferable. And if the score is greater than or equal to 2, then the patient is at high risk, and warfarin should be used unless there is any particular contraindication. So let's start by talking about heparin. This is a very complicated slide that shows the different pathways involved in coagulation. And if you remember from your days of hematology, there's an intrinsic, an extrinsic, and a common pathway. Importantly, heparin has its action by potentiating antithrombin 3. This has an anticoagulant effect, mainly because antithrombin 3 is an important deactivator of factor 10 and thrombin. There are two important formulations of heparin. These are the less commonly used unfractionated heparin and, of course, low molecular weight heparin. Unfractionated heparin is a mixture of sulfated glycosaminoglycans and may be administered either intravenously or subcutaneously. Its use needs to be monitored using the APTT, or activated partial thromboplastin time, and the usual range given is between 1.5 and 2.5. In terms of low molecular weight heparin, you probably would have seen this used on the wards already, and examples include enoxaparin, or to use the trade name Clexane, and tinzaparin. These are fragments of heparin that usually have a molecular weight between 4,000 and 15,000. They have a more predictable absorption, and thus there is no need for monitoring, and they are also administered subcutaneously, usually once per day. In terms of the important adverse profile, you should be aware of a couple of side effects. Obviously, being an anticoagulant, heparin can cause bleeding, but other ones to be aware of include thrombocytopenia that typically occurs a number of days after starting heparin and is thought to be immune-mediated, osteoporosis, which occurs with the long-term use of heparin, hyperkalemia, due to inhibition of aldosterone. It's also important to be aware of some of the contraindications to the use of heparin. This is a complicated area and advice should be sought from a hematologist, but some important examples include bleeding disorders, peptic ulcers, recent cerebral hemorrhage, so cerebral hemorrhage strokes, severe liver disease, and severe hypertension. The effect of heparin can be reversed using the agent protamine sulfate. So let's talk a little bit now about warfarin. Warfarin is a very important drug, and it's estimated that up to 1% of the population is in fact on warfarin. In the hospital setting, this will often be higher. There are two important mechanisms that you need to be aware of in terms of warfarin. The anticoagulation mechanism occurs via the inhibition of vitamin K reductase, which is a coenzyme that's important in the activation of factors 2, 7, 9, and 10. That's the vitamin K-dependent clotting factors. By inhibiting this coenzyme, you therefore reduce the activation of these factors. However, it's also important to be aware of an additional effect that warfarin has. This is the inhibition of protein C and S. As protein C and protein S are in fact intrinsic anticoagulants, warfarin therefore has an initial procoagulant effect that needs to be countered by the use of heparin. Warfarin is an exceedingly difficult drug. It has variable pharmacokinetics, and even though the serum levels of warfarin will peak 1 hour post-ingestion, no change in the INR can be seen for up to 16 hours, and the maximal effect of a single dose of warfarin is usually not seen until about 60 hours after it's administered. It is a highly protein-bound drug, therefore changes in albumin can affect the availability of the drug, and also warfarin itself is metabolized by cytochrome P450, and therefore any of the drugs that affect this liver enzyme can result in changes in the INR. There are a number of important target INRs that you need to be aware of in terms of warfarin therapy, and I'm going to go through these now. In the context of a single DVT, the usual target INR is between 2 and 3, and most centers would recommend treatment for between 3 and 6 months. In the context of a PE, once again, it's between 2 and 3, but most centers would recommend 6 months. For atrial fibrillation, perhaps high-risk atrial fibrillation, so that's a CHADS 2 score greater than or equal to 2, you would continue the warfarin indefinitely with a target INR of 2.5. In the setting of a recurrent idiopathic DVT or PE, you would continue warfarin indefinitely, once again, between 2 and 2.5. So as you can see, most patients will have their INR maintained between 2 and 3. The most important exception is for patients with mechanical prosthetic valves. These patients need a higher INR, usually between 3 and 4, and must continue their warfarin for life. The most important side effect of warfarin is bleeding, particularly hemorrhagic stroke, and it's estimated that 0.5% of people on warfarin will suffer one of these per year. We've already talked a little bit about the cytochrome P450 inducers and inhibitors, so try and figure out for yourself what these agents are and how they will affect the INR. Other important contraindications include pregnancy. Note that warfarin is at its most teratogenic at 6 to 12 weeks and therefore is absolutely contraindicated in the first trimester. It is safe in the second and is relatively contraindicated in the third because of the risk of bleeding at delivery. Other important contraindications include severe hypertension, as this increases the risk of hemorrhagic stroke. Lastly, if a patient's going to be on warfarin, they're going to need to attend clinics and GP appointments to have their INR checked. Therefore, poor compliance is also a contraindication. Obviously, if the patient is at risk of falls, they should not be started on warfarin. So in terms of starting a patient on warfarin, remember that warfarin has that initial procoagulant effect due to inhibition of protein C and protein S. Therefore, low molecular weight heparin needs to be started simultaneously. It's usual to continue low molecular weight heparin until 24 hours after the INR is within range. As I've already said, patients who are on warfarin need regular checks of their INR. However, once stable, these can become less frequent. There isn't time in this podcast to go into the precise guidelines for starting warfarin. However, if you wish to get more information on this, I highly recommend looking at sign.ac.uk, where these may be found. In terms of monitoring and adjusting therapy, as a junior doctor, you will often be asked to prescribe warfarin for patients that you don't really know. It's a bit of a hit and miss affair, but you should certainly try and remember some key principles. Remember that a given dose of warfarin will have no real effect for about 16 hours on the INR, but may hang around in the system for a long time and have its maximum effect at about 60 hours. Also remember that INR tends to fluctuate slightly, so do not try and chase the INR too much. If you do change the dose of warfarin, try to stick with it for at least 2 days until you can actually see an effect. And remember, there's no need to check the INR daily in a hospital patient unless it is very, very high or the patient is exceedingly unstable or perhaps going for surgery. In terms of dealing with aberrant INRs, the most recent guidelines from the British Society of Haematology are as follows. In the context of the INR being slightly high, so greater than 0.5 above the target but less than 6, you don't need to do anything. Simply perhaps reduce the dose of warfarin and restart at the normal dose when the INR has come down. In the context of a high INR but with no bleeding, you should stop the warfarin and restart when it's less than 5. If the INR is very high indeed, so greater than 8, or there is a minor bleed, you should consider stopping the warfarin and administering vitamin K. Vitamin K takes about 6 hours to work and has quite a long half-life. And also be aware that the oral route is just as efficacious as the IV, so you don't need to go rushing in giving IV vitamin K. In the context of major bleeding associated with warfarin therapy, you should of course stop the warfarin and consider complete reversal. And you do this either using clotting factor concentrate. However, in many hospitals this isn't available and it's quite expensive, so you may need to use fresh frozen plasma. Lastly, in this podcast, I want to talk just very briefly about thrombolytic agents. The important indications for thrombolytic agents are in the context of ST elevation myocardial infarction, arterial thrombus formation, stroke, and for life-threatening pulmonary embolus. You need to be aware of streptokinase. This is one of the oldest thrombolytics and has its mechanism by turning plasminogen into plasmin. Importantly, however, streptokinase is immunogenic, so it can only be given once. It's usually given as an infusion over about an hour. In terms of the adverse profile, there's a number of contraindications for administering streptokinase. These include having ever had a hemorrhagic stroke, having an intracranial neoplasm, having severe hypertension, having had any type of stroke in the last 12 months, having cavitating lung disease, and finally proliferative retinopathy, as this will increase the risk of bleeding. The other group of thrombolytics that you need to be aware of are the tissue plasminogen activators. TPAs work as serine proteases and cleave plasminogen into plasmin. Unlike streptokinase, these are not immunogenic, and there is some evidence that they are in fact more effective than streptokinase and have an added benefit when given with heparin. However, note that there is a slightly increased risk of stroke. In terms of specific examples, it's really important to know these two. Alteplase, which is given as an infusion, and tenecteplase, which is given as a bolus. So that just about completes this podcast. We've talked about heparin and warfarin, how these particular drugs work, some of their important indications, and their adverse profiles. So, thanks for listening. The next podcast that I'm going to do for CPT is going to be on oral hypoglycemic agents. If you have any questions about this or any of the other podcasts featured on podmedics.com, please do feel free to get in contact with me at ed@podmedics.co.uk. Thanks for listening and see you soon.